Welcome everyone and happy Social Work Month. My name is Annette Johns and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador College of Social Workers. I have the honor of being the moderator for today's education event, Assessing and Treating Clients with Complex Needs from Within a Four Directions Holistic Framework. We have over 1,000 social workers from across Canada registered for this event this afternoon, so that is very exciting. This year's Social Work Month theme, Social Work is Essential, highlights the important and essential role that social workers have in the development, management, and delivery of health and social programs. Through our work in diverse fields of practice, we are making a difference in enhancing the health and well-being of individuals, families, groups, and communities. Today's webinar is a collaboration between the Newfoundland and Labrador College of Social Workers and the Canadian Association of Social Workers. And it's so wonderful when we can come together as a profession to learn from our social work colleagues and enhance our knowledge and skills in providing clients with the highest quality services. And sessions that focus on a therapeutic approach, theory, or clinical intervention always generates great interest. The webinar presentation will be approximately 60 to 65 minutes, followed by a question and answer period that I will moderate. Please note that all the details you need, like how to access the slide deck and other housekeeping information, can be accessed through the widgets across the bottom of your webinar platform. You can also resize and move around any of the elements you see on your screen to customize your viewing experience. During the presentation, I encourage you to type in your questions using the question mark icon widget at any time, and I will begin asking them at the end of the presentation. Please note that only the presentation team can see the questions. I now want to introduce our speaker, Elizabeth Shepherd. Elizabeth is a founding member of the Halapu First Nation Mi'kmaq Band and past co-editor of the national journal Canadian Social Work. She has a thriving part-time practice specializing in trauma and EMDR and is employed as a full-time social worker at TARES Clinic, which is an adult outpatient mental health therapy clinic with Eastern Health in St. John's, Newfoundland, Labrador. She is also a contributing author of a chapter addressing the challenges of differentiating depression and grief with clients in crisis in an upcoming Routledge publication, New Techniques of Grief Therapy, Bereavement, and Beyond. Elizabeth received both her BSW and MSW from Memorial University and has a keen appreciation for research as an opportunity to facilitate positive change. In her almost 29 years as a clinician, she has been fortunate to work in diverse fields of practice, including justice, acute care, rehabilitative medicine, and community mental health in Toronto, Halifax, Corner Brook, St. John's, and Sheshatshiu. Elizabeth believes that the diversity of her clinical experience has broadened her appreciation for many variables impacting a client's presentation and treatment, and that understanding how these variables intersect significantly impacts treatment success. She specializes in treating multi-problem clients experiencing complicated grief, depression, clinical anger, and trauma. Elizabeth has 2 teenage sons, one of whom is an aspiring social worker, so that's pretty exciting. This is Elizabeth's 3rd national webinar that she's facilitated over the past few years, and I'm really looking forward to the presentation this afternoon. And on that note, I will now pass the virtual podium over to Elizabeth.
Well, thank you very much, Annette. What a lovely lead up. I am so excited to hear that there are 1,023 social workers across Canada who are interested enough in this topic to spend an hour and a half with me today. So welcome, everyone. I'd like to thank NLCSW and CASW for inviting me back. I was really excited and humbled to think that maybe so many people might be interested in hearing what I just have to say for the 3rd time. So I hope I don't let you down. So when I was asked by Annette to present today, I was really struggling with the idea of, well, what could I present that I haven't already talked about? Because the past presentations I've done have been around grief. And I thought maybe this might be the time to incorporate some of these other issues that I do in my daily practice and how they intersect with my cultural identity. And that's not something I've brought to the table before, so I'm hoping this is useful for you. So why don't we begin? At the conclusion of this webinar, my hope is that each of you will have a greater understanding of the individual treatment considerations and approaches when working with complex cases, that you will each feel confident in identifying priorities and goal setting with complex cases, and that you'll also be able to recognize the value of wholeness and balance in approaching clinical goals. I want to have a little disclaimer at the forefront, though, that this is really not meant to be a pan-Indigenous presentation. The material that I'm going to be presenting here today is really a reflection of the teachings that I have received from within the circle of my community of elders and teachers. And each nation has their own teachings, and while some might be very similar to what I tell you about today, others may also be very different. So the presentation is really not meant to infer that this is the best way or the only way to view things, but that this is the way that I have constructed meaning in my own practice. So, as is the custom in Indigenous sharing, it's really important that I begin with who I am and who my teachers have been. As Annette mentioned, I am a member of the Halibu Mi'kmaq First Nations band here in Dahamguk, Newfoundland. My bloodline comes from Johns Beach in Corner Brook area on the west coast of Newfoundland. Dahamguk is how we say it in Mi'kmaq, with connections to Nova Scotia. And that's the Prosper line, so if any of you in Nova Scotia know Prospers, I'm probably related somehow. I've learned an awful lot about my culture and language and music from some really important people, some teachers and elders that I've been very fortunate to connect with. And I just want to take a moment to say a little bit about who they are. Joanne Prosper is an elder within my bloodline who has been extremely gracious and kind in sharing her knowledge and wisdom with me. For those of you from Newfoundland, you may know Dean Simon. He's been really instrumental in getting Mi'kmaq language going at a community level, and he's got some programming that he's offering right now with Halibu. And there's 240 of us in his language seminars. He's been extremely helpful to me for many, many years, even before he started working with Halibu. And when I told him I was doing this presentation, I asked him, how do I say social worker in Mi'kmaq? And so we figured it out, and I'd like to introduce myself and say that my name is Elizabeth, and I work as a social worker. Here's what I say that in Mi'kmaq. Elsabet Daluisi Undilguaham Nuji Abo Hanamawet. So now you all know how to speak Mi'kmaq. I also want to mention Paul Pike, who is another significant person within our community in Newfoundland. Paul, during the pandemic, did some really great things with the people of the Dawn Indigenous Friendship Center in Stephenville. He really fostered a lot of communication between all of us who were scattered and isolated, and he's been doing these 30-minute information sessions, sort of check-ins, where we talk about culture, and he plays a native flute. And he's inspired my sister and I to actually take native flute lessons that he's going to be hosting starting next month. So, Wilal and Paul. And lastly, we have Ken Paul, who's been a really dear friend to me. He is with the Wolastoqey Nation in Tobic, New Brunswick. And he is really my silent partner in this presentation because it is the knowledge that he has so graciously shared that has formed the foundation for a deeper understanding of what the four directions are. So he taught me that stuff and said, okay, Elizabeth, go figure out how to put social work into it. And so Walal and Paul, Ken have been very, very helpful. So I want to express my appreciation to each of those people and to the others that I've intersected with along the way. You've all been very helpful. I do want to say that Ken got most of his teachings from some really informative people, from Gwen Bear, the late Gwen Bear, who was an elder within his community in Tobic, from Maggie Paul, who is quite prolific, and most of us here in Halibu have known her name, and from Albert Marshall and some other really significant people. So I've had the benefit of some pretty impressive teachers that he's had as well. So that's been very, very fortunate for me. So in addition to my Indigenous background, of course, I've been a clinical social worker for almost 29 years, and I have spent many years working with Indigenous clients in Newfoundland and Labrador, and of course in other places in Canada as well. What I've discovered is that many of the strategies that I've taught my clients over the years has really been an instinctive integration of social work ideas mixed with my culture. And these ideas that I share with you today are born of these teachings. And my integration of these really two essential parts of my identity And I hope that they're useful to you today as you continue to navigate your own journeys as clinicians, integrating the meaning of culture into your own practice. So when I was coming up for the name of this topic, I sort of giggled when I said complex cases, because really and truly every area of social work can be complex, and usually is. I don't think I've ever had a single case that's been simple. But what happens is the demands of these cases on us as clinicians can be really overwhelming, and especially when we're dealing with the challenges of living through a pandemic. I know that I'm challenged to manage the same way, and our clients certainly are as well. So understanding how to best intervene comes with a basic understanding of the notion of balance. And as an Indigenous social worker, I draw upon the teachings that I've gotten to conceptualize this. So here we have a medicine wheel. Many of us probably are familiar with this to some degree. I know I just painted one on my mailbox, so I'm very well acquainted with this. And so we see a circle, and we see it divided into four equal portions or quadrants. So the four directions holistic framework comes from the medicine wheel, and we use the compass. So the top we have the north, the bottom is the south, to the left is west, and to the right is east. So just like on a compass. And in this model, individuals are viewed to be healthy when all of the four quadrants of the framework are in balance. And the Indigenous philosophy is that lack of balance leads to illness. So really this medicine wheel is about health. Now, as social workers, we know that whenever we experience something significant, be it positive or negative, we experience change. And change results in imbalance. We are forced to tend to the impact of the change as we try to make sense of it, regroup, and move through it. And sometimes we get stuck and have trouble rebalancing, and we need some help. And that's where we come in as social workers and therapists. It's our job to help our clients correct and rebalance in order to achieve wholeness. Social workers, we're just agents of change, and we always have been since we came along. We generally only become involved if there's a lack of balance somewhere in the system. And while we strive to work proactively to prevent imbalance and challenge, far too often our roles come into play in response to difficulty. And so that can be if we're working in the healthcare system, working on a floor, we might be getting a call to help a client that's having trouble getting discharged, or somebody who maybe was admitted with a suicide attempt. It could be in child protection. We have to intervene into a family that's in distress. All of these are systems out of balance, and clients who are looking for assistance in finding that balance again. So for this reason, understanding the importance of balance and the principles that we can use to assist our clients as agents of change are very critical. So if we go back to our medicine wheel, we use this model to address our health. We can see that our four core needs are represented in each of the directions. So in the north, we see our mental needs. In the south, emotional. In the west, physical. And in the east, spiritual. So the four components of who we are as individuals. Each of these four quadrants gives us an ability. My body gives me the ability to do physical things. My mind gives me the ability to think and reason. My spirit gives me the ability to see and envision. And my heart gives me the ability to feel emotions, compassion, and empathy. Now, sometimes people think that spiritual is really about religion, but it doesn't have to be. It can be for people who are really connected to their religion, their faith. But usually what we see is when people close their eyes and they pray, they will ask to see. They will try to envision something that's happened in the past or something that they want to happen in the future. And when we are tending to all four quadrants, we have balance and health. Unfortunately, this is challenging for our clients and also for us as social workers. There are frequently demands that mean we place more emphasis on one quadrant over another, and this, of course, creates imbalance and distress. So if we understand that change can lead to imbalance, and that is why our clients are coming to see us in distress, how do we intervene most effectively? That's the challenge. Well, we have to prioritize need by determining the area that will impact the greatest return to balance. This always begins with safety, which is the quadrant to the left, the west quadrant, physical. If the client is not alive, then there's no other goal that can be attainable. And that sounds very glib, but we always have to start with safety. Now, for those of you who know me, or who've listened to me talk before, everyone knows that I'm a big fan of Maslow. And I learned this in one of my early years in social work in my BSW program, and I still have a picture of this hierarchy of needs on my bulletin board because I think it's really, really relevant to us as social workers. So if we go back to Maslow's hierarchy of needs, we will see the order to proceed, okay? We look at the bottom of the pyramid, and that's physiological needs, and that is the need for air, food, water, and health. And of course, safety is health. Now, we can look at the different components of issues instead of the issues themselves in order to attain our goal progression. So, if we have a client with a lot of different issues, we look at what parts of them are impacting safety. So it could be the suicidality of depression. We might deal with that before we would deal with the social part of the depression, the isolating behavior. So the basic rule of safety must apply in determining case planning. And so here are some things to think about. Is the behavior in any one area jeopardizing your client's safety? So for example, if you have a client with depression, is the depression creating risk to self by having this suicidal ideation? And if so, you need to address that. If you have a client who's experiencing trauma, is the trauma triggering hopelessness and feelings of suicidality? Again, if that's the case, you need to do that first. If you have a client who's experiencing grief, is the grief creating feelings of wanting to be with the one who's passed away? If so, address that. And finally, if you have a client with clinical anger, is the anger pushing all the supports away and limiting connection that is life-sustaining? I think for many of us, we don't automatically go there with regards to treating anger, but as we'll discuss later on in the presentation, when somebody goes through a clinical anger response, they can have very few social supports, and they can put themselves in a situation where suicide may seem like the best option. So we always have to check for safety no matter what the issue is. And these are just a couple of issues. My point is, no matter what area of social work you're working in, whatever the issue of the client is, you always start with safety. So once safety issues, which is the physical quadrant, of course, once they're addressed, from whichever issue they originate from, we really have to let the client dictate the area's importance in goal setting. Now, I'll usually make sure the client's safe, and then I'll say something like, so what would be most helpful for you today to talk about? And they may have a shopping list of issues, but it's not really up to us to decide which is the most significance. We can do our assessment and determine which one is causing the biggest impact, but it has to be something the client buys into. So we can assess and determine problematic thought and behavior patterns that are barriers to balance, but the client must be a partner in treatment planning. It's no good for us to start working on an issue that the client is really not invested in, because it will not result in balance. So let's apply this to some common presenting issues. If we break this down a little bit further and we look at some of the more common issues, let's see how this would work. I deal with primarily 4 issues. Of course, there's lots of different things that come up in treatment, but the 4 big ones that I use are grief, depression, trauma, and anger. And so I'd like to apply this stuff and Maslow's work and the 4 directions to those 4 areas. Let's see what they look like. Grief. Wow. Grief, by definition, is a multifaceted response to loss, particularly the loss of someone or something that has died, to which a bond or affection has formed. And I think we all kind of have a working knowledge of grief. We also know that there's a couple of different types of grief. The first one is adaptive grief, and that's the normal, sort of a healthy grief. And although the process of grief is individual, on average, a typical course of grief or bereavement might last 1 to 2 years, with some intermittent symptoms throughout the lifespan. And also in adaptive grief, we see that when grief moves forward, the survivor gradually integrates the loss into his or her narrative while drawing some attachment security from the backstory of a loving relationship with the deceased. In comparison, complicated grief is just a little bit different. That occurs when there's something that interferes with the learning process that is the core process of healing. And the results are for the client feeling that they're really stuck in the rawness of that acute loss. I have a little graphic here that sort of makes it a little bit more simple to think about. So in one column we have adaptive grief and the symptoms, and in the other we have complicated. So in adaptive grief, the client can acknowledge the reality of the death. They're not happy about it, but they are accepting that it happened. Whereas in complicated grief, that's a struggle. It's tough to accept it, and they may avoid reminders of the loss. In adaptive grief, the client is able to retain access to the bittersweet emotions. So they might say something like, oh, wasn't that funny when mom used to do that? And everyone would have a little laugh. They'd still be sad that they lost mom, but they were able to connect to the happiness of those funny moments. Whereas in complicated grief, the client has a harder time doing that because they're really stuck in that pain of loss and they just can't access anything positive. In adaptive grief, the client is able to revise how they remember the deceased and the bond that they shared, whereas that's not possible in complicated. They're really stuck in those relationship and separation distress issues. And in adaptive grief, the client is able to redefine life goals and roles. And so for that, we usually mean they might say, oh, mom always wanted to go to Europe and she didn't get to go. I don't want to have any regrets in my life, so I'm going to make sure that I do the things I want to do while I can. And in complicated grief, they're just not able to extrapolate that way, and they can just get really stuck in the story of the client's death and not be able to do anything other than that. So clients can experience short-term and long-term imbalance as they experience both types of grief. And so I want to be clear to say that there is really no easy type of grief. It's just that the complicated grief is a little bit more involved in terms of treatment. You can have a client who's experiencing adaptive grief who's really, really struggling, and that's not unusual. So there's going to be a period of imbalance with that as well. But the idea is that with some integration of newness, of change, eventually the client will find that balance. And it may be with our help, but it's a little bit easier for them to do that. In complicated grief, however, our clients really get stuck in that imbalance, and that can lead to some real significant issues in each of those quadrants that we discussed. So I want to just kind of show you a little bit about how that looks. So here we have the medicine wheel again, and you'll see that instead of having the quadrants all be proportional size, that some of those quadrants are a little bit bigger. Now, this is my own interpretation. This is not something that I've gotten from any of my teachers. They've told me about the idea of imbalance, and I've sort of conceptualized it to address grief response in this slide here. But if we think about the ways that our clients are usually responding to grief, a lot of them have a lot of issues with, a lot of heavy emotion. So in this one, you see in the South, in the emotional response is they might feel a lot of anger, they might feel numb or stunned, or they might be really isolating from their supports. And of course, in the South is where we see a lot of the relationships as part of the medicine wheel and the connection to community and family supports. So that might be really significantly impacted there. We also see in the East, in the spiritual piece, a lot of clients experiencing a lot of turbulent grief emotion will start feeling that life has no meaning. They have really acute separation distress and hopelessness. And so it's really difficult for them to envision a life without their loved one. You see that there's an arrow there and the word fear. And so the Indigenous teachings is that when we have disproportion in our medicine wheel, in our four directions, it comes from an underlying fear. So something is driving the wheel out of balance. And often it's fear. So it may be that the client is fearful that they will forget something about the loved one. They're unsure how they will go on. They're unsure how they will survive this. And it's that fear that can really impact the ability to cope and the disproportionality in the quadrants. So those are two of the big things that we would see. Of course, everyone's grief response is different. In this one, you see as well that they still have some issues in the other quadrants. A lot of times when people are experiencing grief, they will have poor sleep, poor appetite, and they maybe not want to get out of bed, which can impact their hygiene. They probably have a hard time getting a shower, and they may not want to do anything physical. As well, in the north, we see the mental piece is impacted. The client can have trouble just kind of accepting the finality of death, and they may avoid reminders of loss. There may be a lot of ruminating thoughts, and so these are some really big challenges as well. So this is what a grief response can look for some people. So Indigenous teachings tell us that the way we rebalance is by love. We help the client connect to love of themselves, so self-love, appreciation of their abilities and skills and who they are as human beings, their connection to family, to community, nation. These are all the ideas of experiencing love at several different levels, micro, macro, meso, of course. And the love of self includes correcting imbalance in every quadrant. What we would do, of course, is we would help them with that. So if you look at the same medicine wheel, what I've done is I've put in some different things here now. You see that the first thing that we always do is we go to safety. So we would always go to the west. We would start to make sure that that client is safe. And if we make sure that they are, we check in that and we're okay, we're great, then we would continue on assessing the other variables in the client's life. The overall purpose would be to determine what things are driving the balance out of proportion. Okay, so if we look to the bigger quadrants, if we look at the spiritual part, in the east, we see that the client may feel that life has no meaning, separation, distress, and hopelessness. So what would we do as social workers? Well, we could connect them to some mindfulness, to connect to some things that are bigger than them, to give them some hope, to connect them through some strategies, maybe through ACT, through narrative therapy, which is something that I practice a lot of, to reestablish that connection and to inspire hope. So we might help to decrease that fear that the client is feeling, that they have lost connection to the loved one, by helping them to find some ways to connect with them now. If you look at the mental part, we might do some things around those challenging cognitions that the person might have, those ruminating thoughts that things are never going to get better, and that they're not sure how they're going to survive without their loved one. And we might do that with CBT, or with ACT to accept the loss, of course. I do tend to use EMDR quite a bit in dealing with people who are really struggling with loss. And of course, you have to be trained in order to use EMDR. And I've been using it for, I guess, about 2 years now, a little bit more than two, almost 2.5. And I have to say it's really, really efficient in helping people to process grief. So I would use that if it was me and I was approaching this case. From the physical point of view as well, what we want to do is we want to say, okay, look, there's a lot of imbalance there. What are we going to do about that part? We need to sort of, again, as we're figuring out where the biggest part of that loss is, look at some sort of behavioral activation and sort of think about some of the things that might be helpful there. And so that might include getting them moving, developing some goals around exercise and sleep, hygiene, food, and maybe working with the medical care team as well, because if there's a lot going on, that family doctor is probably a really integral part of this person's life. And if they're not, they should be. There may be some medication needs that are important there, and there may be some other pieces involved. In addition to the grief, there may be a depression there or something else. So we really need to involve a number of community partners in making sure that we have best possible outcomes for this client. When we look at the emotional point of view, we see that, a lot of the sort of coping strategies that we talk as therapists, really, they have an overreaching goal of establishing that connection to the deceased. And that really does go back to the spiritual component, but it also fits within the emotional as well. So a lot of the therapies may be addressing both quadrants. And so what we want to do is we want to help the client recognize that even though that the person has passed away, that they can still maintain a healthy connection. And that can really help them in reestablishing that balance as we are able to remediate some of that fear. Of course, the sadness is going to remain, but in time with some strategies, they may feel that it's a little bit more manageable and less life interfering. Some of the things that I will do with regards to some narrative interventions, and I have talked about in past presentations for CASW, are some things that would be really useful in that quadrant. And that might include things like directed journaling, where we would be really specific in the questions that we would give our client to journal about to help them have a better connection to how they're feeling and what the loss feels like. We could also do some gestalt chair work, the empty chair stuff, where the client would maybe direct some unresolved issues towards imagining that the client was there in the room with them in the empty chair, and you could facilitate conversation with that loved one. That's quite powerful for many of our clients. I've also used a technique called correspondence with the deceased, where, again, if you see people who are really stuck and they have some unresolved issues around the death, they would do things like write a letter to the deceased with all the things that they have not been able to resolve. You can do all kinds of cool things with that. You can have it as something that they would do when they bring it back to a therapy session. Or I've had them actually have the use of ceremony in the chapter that Annette mentioned. That seems like it's never going to be published, but I'm promised that it's going to be published in August. The chapter that I wrote talked about a client who was able to write about her own complicated emotions around the death of a parent. And so that person was able to write a big long letter to mom and in front of a fire pit with her partner, read it aloud, was able to express everything that she felt, threw it into the fire pit, burned it, and then buried the ashes in the flower garden around her parents' favorite flower. So it was quite symbolic and useful. So writing those letters is extremely helpful. The other thing that you can do along with that, in addition to using those sort of ceremony things that come with narrative therapy, is you can have the client write that letter and read it aloud, but then in therapy you can ask them to write a response from the deceased, and that can be extremely healing. So those are some things that I get people to do. A last one I will say that might be useful for younger people is a technique called playing with playlists. And what that does is it really traces the narrative of loss with music. So you might choose different songs that would represent different stages of the relationship with the deceased. So it might be some songs that they remember from, if it's a parent, some songs that maybe their parent used to sing to them, or some favorite childhood songs, and songs that might sort of make them think about their parent. And they can use that playlist to play whenever they want to get in touch with that grief, to feel connected to that parent, as an opportunity then to use that time to grieve and to heal. So a lot of different things that we can use in terms of just kind of being able to do that. The nice thing about the work that we can do in the mental quadrant, however, with regards to the narrative part, in keeping with narrative vein, is that a lot of times people are feeling very overwhelmed by these things. And so we just want to be able to externalize that grief and help them to see that it's not something that is central to their identity. They can certainly move through it the best way that they can. So those are some of the things that we deal with when we're talking about grief. So major depression is something that kind of goes along with grief. And so it's really important to kind of talk about that as well. And I think what can happen is we can sometimes miss that there can be several components that go along with something that our client is feeling, and that there may be a depression in addition to the grief. So it's really important to recognize that you can have both things at the same time, so you can grieve and be depressed. So always keep an eye open for that. Let's talk a little bit about what clinical depression is. So major depressive disorder, MDD, is also known simply as depression, is a mental disorder characterized by at least 2 weeks of low mood that is present across most situations. It's most often accompanied by low self-esteem, loss of interest in normally enjoyed activities, low energy, and pain without a clear cause. So it's inherently a very cognitive-based thing. So we want to make sure that we always keep an eye on the mental component when we're thinking about that. Now, let's have a little look here about this slide to sort of tell the difference, because again, there can be an awful lot of overlap with grief and depression, which is why sometimes it's easy to miss depression in a client that's grieving. So let's look and see what some of the defining differences are. So if you have a client that's coming in and they're telling you that they're isolating, that can be for 2 different reasons. Well, it can be for lots of different reasons, but in this slide, we'll look at the difference because you want to sort of explore why they're isolating, not just to say, okay, they're isolating. So in a typical grief, the client may isolate, but they might generally maintain some pretty close emotional connections to others. So they just might want to spend some time by themselves being sad, and that's okay. But in depression, a lot of the times that isolation is because they're very, very self-focused. They may feel very alienated or like an outcast from friends and loved ones, and they might just genuinely feel that they are alone and they don't want to be around other people. We see more hope in grief than we do in depression. So a lot of times people who are grieving, even though they're terribly sad and overwhelmed, they will have a belief that the grief will probably end or get better someday, or at least some hope for that. Whereas in depression, there's a sense of hopelessness, and they believe that they're never going to feel better. The depression will never end. As I mentioned earlier, depression is really cognitively based. So a lot of people who are experiencing depression will have low self-esteem and self-loathing, whereas that's not really present for the most part in grief. Most people are able to maintain overall feelings of self-worth. And you can also have guilt in both, but they're for different reasons. Someone experiencing a grief response will generally feel like maybe they let down the deceased person in some way, and they'll feel guilt for that reason. Whereas in major depression, it's often a feeling of worthlessness or uselessness, and that's where the guilt is coming from. Some other defining characteristics are anhedonia, which is a persistent loss of feeling anything positive. And you'll see that in depression. They don't want to do anything. They have no interest in it. Whereas in a grief, you may have some loss of pleasure, and it's usually because they're longing for the deceased. And so I'll give an example that maybe you used to go to bingo with your mom, and so suddenly you don't want to go to bingo anymore because she passed away, and there may be an association, so it doesn't feel fun anymore to do that. A lot of times when people will talk about wanting to die, we will all sort of panic and go to, red alert. But it's one of those things that you're going to screen for no matter what the client is experiencing, what issue that is. So in a typical grief, that client may want to die because they lost their loved one. But if that loved one wasn't dead, they wouldn't want to die. So it's really just very situational and grounded in the fact that they had a loss. Whereas in depression, it can be, most of the time, it's chronic thoughts of not wanting to live. In depression, we also may see that clients may feel some comfort in being with others, or by music or literature or hobbies, those kinds of things. But in depression, they're often inconsolable. And ruminating is a really big one for both as well. So ruminating is your mind is spinning. And so clients will say that when they're grieving, if only I'd made them go to the doctor sooner, or if only I'd done something. And people can get really stuck in those thought patterns. Whereas in a major depression, that rumination is usually about feelings about being a bad person, a burden to others, or thoughts that nothing good happens in the world. So again, very, very self-focused, very cognitively based. Okay, so What would that look like on a medicine wheel? It's a lot of stuff. So again, we're looking at my sort of representation of that. Again, this is not something that someone told me this is how it looks, but some of the clients that I've had would probably look like that. And so we see here in the north, in the mental quadrant, some of the behaviors that come with depression. We see self-loathing, low self-esteem, and suicidal thoughts. And that's making that quadrant pretty big because it's a really huge component of depression. And we also see that the emotional quadrant to the south is out of proportion as well. And we're seeing that a client feels misunderstood and alone. They're isolating from their supports, and they're feeling angry and sad. So those two quadrants are getting the most pressure from this illness. And we're seeing to the to the west, that the client is experiencing some very physical symptoms, and we know this is the case. Poor sleep, appetite, and hygiene. They may have a really hard time getting out of bed. That can be significant. They may have a hard time even leaving the house. And again, to the east, in the spiritual quadrant, we see a lot of persistent hopelessness and feeling that there's no future for them. So if we go back to our Indigenous teachings again about how do we most help our clients, we would go back to that feeling of love, facilitating that connection to love of self, family, community, and nation, recognizing that this inherently balances the system in the medicine wheel. So that love of self, again, includes correcting imbalance within every quadrant, and that's where we come in. So here we have behavioral activation. And so if we think about depression in terms of how it looks like here, again, the first thing we're going to do is ensure safety. So we're going to do that every time, and that is part of the assessing the variables part, but it's the very first thing that we assess. We want to make sure that we have safety because we know that a really big part of depression is suicidal thoughts. And it's a normal part, but it's a really scary part for the client, for the family, and sometimes for us as clinicians. So we have to make sure we always ask that question. Have you thought about harming yourself? Do you have a plan? Do you have the resources, etc.? And there's there's lots of great suicide risk assessments that you can use. I guess for those of us like me who've been doing it forever, we just instinctively know what to ask. So we make sure that there's safety. And if we look, we always do that. We want to make sure that if depression is a big issue and we're working with that client, we want to make sure that they have a good medical team involved, that they are connected to their family doctor or their psychiatrist, and that medical team is very aware of any change in symptoms, and that that person can figure out with you if the low mood is in response to something that's situational, or if it's something organic that's biochemical that needs treatment. We want to make sure we understand what the variables are that are impacting that balance. So that part's really, really, really important. So we're going to look at, from a behavioral activation point of view, how we would handle this. We're looking again after we do safety. We look there in the west. We would do some behavioral activation around setting some different goals. Now, one of the things that I've been doing since the dawn of time, without even recognizing that it was part of my Indigenous teachings, is I've been asking people to have some 4 different goals for every day. And setting those goals, they set them before they go to bed in the night. And these help them get up in the morning and to choose goals. I usually have people look at an exercise goal, which of course is physical. And exercise is really important for dealing with depression because we know that 20 to 30 minutes of exercise at least 3 times a week has a biochemical impact that's very similar to a low dose of an antidepressant. So it's extremely useful for them in terms of managing mood. So we want to get them to move. I usually say every day, but again, it depends on what people's issues are. We want to get them to eat every day. With depression, we know that people don't have an appetite, so they may have to set an alarm on their phone to go off and eat because they won't be able to have a physical cue. And we want to get them up washing and having a shower because, of course, that makes people feel better as well. So these might be some of the things that we would get them to do. So I usually get them to do a physical goal, which is exercise. I get them to do a mental goal, which is a productive goal. And that might be something like, call your doctor if you need an appointment, make a shopping list, something that at the end of the day you feel like there's something productive that they can reflect on, they can feel good about, and they feel like, oh, it's great, I finally got that done, and I don't have to worry about that anymore. I usually get them to do a social goal as well, which comes from the emotional quadrant, which is about social relationships. Because we also know that depression is very isolative. And so what we do with depression is we do the opposite of what depression wants. Depression wants you to isolate, so you have to connect. So choosing to do something, it might be calling a friend, or you can do something that combines quadrants, like go for a walk with a friend. That's great too. And I also get people to do a self-care goal, which again can fit it within the spiritual realm. So it's about connecting to something that feels good. We need to have connection in order to feel balanced. So again, the 4 goals that I get people to do every day: we do an exercise goal, which is physical, productive goal, mental, social goal, which is emotional quadrant, and self-care, which is spiritual. I have them do that before they go to bed every night, so that they have something to get up for, and I have them identify in their schedule what time they're going to do them, so that, and think about it like it's an appointment, and they're a lot more likely to follow through if they have a specific thing to get up for. A lot of times when people are off work, one day rolls into another and they feel kind of awful at the end of the day. But if they have some structure, which we know is really useful for treatment of depression, that it helps them get through that in a little bit more productive way, and they feel good. So then what I get them to do is, at the end of the day, before they are choosing the next set of goals, reflect on what they did, so make some changes. So if they weren't able to do it, was it that they chose the time of day that wasn't a time that they had very much energy, or to sort of congratulate themselves if they were able to do it. It's not a time to be negative about it. It's a time to sort of make changes as you need to, but it's about kind of helping them to feel like they're moving forward, which is extremely important in depression because people feel super stuck. So that's the behavioral activation part, and I think that's really important part of anything. If we look at this wheel here for the therapy part, we'll see, again, there's a lot of different quadrants under strain here. We have mental and emotional. So in the mental, we may do some things to challenge all those cognitions, which is a really big part of depression. We may do some CBT, which is super successful in that. I think CBT is where it's at when it comes to cognitions. I, again, use a lot of narrative therapy, and what I tend to use it for is externalizing that depression to decrease shame. So a lot of times people come to me and they will feel so humiliated and shameful that they can't go to work, that they can't do the things that they need to do. And so narrative therapy will have you externalize the depression, think of it as a sort of a separate entity. And so what I use it for is to identify that as a force outside of yourself. It's not you that doesn't want to do this. It's depression that's keeping you from doing it. And so what you do is you mobilize resilience against that enemy, against the depression, in order to sort of spot it when it's trying to plant thoughts into your head, so that you can, not fall victim to it. And, if you think about, if depression wants you to do one thing, you do the other, that kind of thing. So people find that that narrative therapy is super helpful with that. And that's a very simplistic explanation of how I use it, but if you're interested in it, I'm sure there's lots that you can, if you Googled it, you'll see lots of stuff. Of course, Michael White's work is always quite brilliant, but there's a lot of interesting things out there. In emotional point of view, we look at, again, narrative in developing some alternate storylines to decrease those thoughts about alienation and isolation. I think that's, again, one of the strong parts with depression is that it wants the client to feel that they are alone and that nobody loves them. And so finding alternate storylines that might be able to show the client that this is really not the case can be very useful in terms of rebalancing that quadrant. If we can rebalance those 2 quadrants with the client's hard work, what we see is there's more room for other things that are positive. So in the West, with the physical part, again, after we make sure that client is good and stable, there may be some things that happens with the medical team. There may be some medication. They may be moving more. They may be eating more. And those things, again, can take up a little bit more space than they are right now within the quadrants. And again, from the East, from the spiritual piece, we would do some things that would really help that client to reclaim hope. And that might be mindfulness, which is really, really lovely. And brief solution focused therapy is really useful to reclaim hope as well, in terms of setting those micro goals that you can work towards and see that movement. So these are some of the things that I usually do in response to depression within this approach. Okay, now trauma. Trauma is something that, of course, is something that a lot of us are seeing right now. It may be defined as a deeply distressing or disturbing experience. And the challenge with defining trauma is that some life events may impact one person greatly and others minimally. It's very individual. The importance in defining trauma with our clients is not against some sort of imaginary meter stick, but rather in terms of how that impacts the client themselves. So, for example, a dog bite might be really traumatic for one client, but it might not be for another one. And a fight with a parent might be traumatic the same way. The key part to think about for all of us is how that event is interpreted by the client. When we get a client who's looking for help, we have to stop and think about the things that we interpret as trauma might not be the same way as they are. And oftentimes my clients will say that, they know that some people have worse issues than they do, and they might feel a little bit of shame at it being impacted the way that they are. What I've found to be really critical in working with our clients is to help them understand that each of us has the right to feel the things that we do, and that our emotional response is quite legitimate. So each of us as clients, as clinicians rather, have already endured various levels of trauma before we even entered this field of social work. And many more of us have experienced trauma in the course of doing our jobs or in our personal lives. For this reason, we all have a working framework for how damaging trauma can be. Now, some of our clients may have a condition called PTSD, and I'm finding that a lot more of my clients are coming in with that diagnosis these days, or they're self-assessing. PTSD is a mental health condition that's triggered by a terrifying event, either experiencing it or witnessing it. And some symptoms might include flashbacks, nightmares, and severe anxiety, as well as uncomfortable thoughts about the event. Most people who go through these traumatic events may have temporary imbalance that results in experiencing some difficulty adjusting and coping, but with some time and good self-care, they usually get better. If, however, the symptoms get worse, they last for months or even years, or interfere with day-to-day functioning, they may have this condition called PTSD, and that's taken from the Mayo Clinic. Now, let's look at how that might look on the medicine wheel. You see it looks very similar to the other one in that the mental and emotional quadrants are quite large. And again, usually with trauma, that's where we see the biggest impact. So we see in the north with the mind, we'll see some of the symptoms are flashbacks, ruminating thoughts, a lot of hypervigilance, and some memory issues. And in the south, in the emotional quadrant, the client may feel very alone, easily startled, angry, sad. They can be aggressive, not always. They might feel numb, shameful, and overwhelmed. And that's in the emotional component. So in the physical, to the west, some of the symptoms might include poor sleep. That might be because they're having a lot of nightmares. And appetite can be impacted negatively. And again, if you're feeling terrible, a lot of the times people don't want to get out of bed because they're so exhausted and they're not wanting to get showers and look after themselves. These are just lesser important than some of the other issues that they're facing. So it's a struggle. In the spiritual, in the East, a lot of times people who are experiencing such terrible symptoms, they feel a lot of hopelessness and they really don't see any future for themselves. So they can be really impacted. Again, if we go back to our Indigenous teachings, we have to remember that love, again, that love of self, family, community, and nation is the rebalancing element that we have to reinforce with our clients. That love of self includes correcting imbalance within every quadrant. So here we go back to a very similar looking slide from our other one, but we start again with safety. When we're assessing those variables, when we start, we have to look at, is that client impacted in a way that makes their physical safety at risk? So we see a lot of imbalance. Those mental and emotional quadrants are much larger in response to the pressure that's placed on that client. The client's really just trying to survive each of these areas, but in doing so, has not very much energy to deploy to the physical and spiritual areas of their life. And so balance and treatment must therefore begin by ensuring the safety first, then with stabilization to these really overwhelmed quadrants. So you see in the mental, we see that there's those flashbacks, ruminating thoughts, hypervigilant memory issues. And so some of the things that we might do is we might look at EMDR or cognitive processing therapy, or CBT to process the trauma, reduce that hypervigilance and rumination. Now, my bias is EMDR because I've just seen it do some really amazing things. So I tend to go to EMDR, but I don't know that I would start with the mental quadrant. I think a lot of times when our clients show up in our office, it's easy to want to go in and fix that part. But I think what we really need to do is stabilize. We need to help that client start to ground. And what happens is they may be having so many flashbacks that they just can't even stay in this realm. It's really difficult to work. It's difficult to have any kind of connection to their family or their loved ones. So really start with grounding techniques when you're working with trauma as a way of making that quadrant bigger. We want that client to feel that they have some degree of control in that quadrant. So I start with that before I do anything at all. And so that might be with some mindfulness strategies to allow that client to be present in their current surroundings and not in the place where the trauma existed, and to allow them to feel safe. That's really, really critical. Connection to their environment and being present in the here and now is a really important component of that spiritual quadrant. So we really want to make sure that we strengthen that one big time. And once those clients are able to ground themselves and recognize that they are safe in the present, they can decrease that emotional response and then hypervigilance to some degree. So then we see that validation, encouraging meaningful connection to supports and facilitating a safe place to share, trauma details can really lessen that overburdened impact on the emotional quadrant. So down in the south. And so, encouraging physical activity as a release of those highly charged emotions would also be really useful to the client. So that sort of behavioral activation part as well, that's really useful. And so that, of course, would be in the physical quadrant in the west. And then I would also, once we get these little things done, just kind of really go in with that EMDR as a practice to kind of help that person process that unprocessed trauma. Now, this is the thing about EMDR, is that it's considered one of the top 2 treatments for PTSD. Of course, the other one is CBT. So whatever your orientation is, of course, go to that. But I have to say, I've never seen anything quite so efficient in terms of treating trauma. And I've worked with some first responders who've had these horrific images in their head that they haven't been able to release. And they've come into my office, and then within 2 hours, the images are gone, and they come back to see me in a couple of weeks, and they're not there anymore. So it's exceptionally efficient in helping with that. So that's not to say that there isn't a role for the other parts. And sometimes you still need to do some work even after the trauma is processed with CBT or CPT. Certainly you use whatever you have, and you basically go wherever the client is. That part's really, really important. So we're doing everything from the medicine wheel perspective. We're trying to make the physical and the spiritual bigger components to take the pressure off of the emotional and mental, to create that balance. And when that client is feeling balanced, then they can start to breathe and they can start to return to a functional, more meaningful life. So that's a tough one. Okay. Now, this is a cute graphic. So if anyone's Inside Out, they'll recognize this little guy. This is anger. And clinical anger, of course, is something I want to talk about now. It's something I do an awful lot of work with in my practice as well. Now, anger is a normal human emotion, and some clients, however, may experience a chronic and pervasive anger called clinical anger. The difference between anger and clinical anger may be comparable to the difference between a feeling of being down and having a clinical depression. So it's just the degree to which it's present. And a common issue like anger generally becomes clinical when it becomes a long-lasting issue. Now, there are many underlying issues that appear to make anger more challenging to deal with, and that includes depression, grief, and trauma, which can all impact the feelings of anger, which is why I wanted to put anger last, because we've already looked at what each of those issues are and what the things are to watch for, and so you can see how understanding what they are can certainly help you have a better understanding where anger might come from. Now, anger develops when our expectations about how we should be treated do not align with what actually happens. The challenge when we have a client who's experiencing problematic expression of anger is figuring out where it's coming from. Where's its origin? Now, anger is an emotion, and it's neither good or bad, it just simply is. And it is the behavior that becomes the challenge in dealing with anger. So a client can experience intense anger, but it only becomes a problem if the way it is expressed impacts the systems that they live in. So this can include the family system, employment, social, and community systems. So it can have a real ripple effect right across the whole, every area that the client is living within. So when we're looking at anger, it's important to remember that the way that the client was socialized can have a very significant impact on the way anger is expressed. Now, this might be including raised in a family where anger was expressed by shouting and throwing things. And the clients learn as children to express emotion in ways that they have modeled. So if they learn that that's what you're supposed to do when you're angry, they just do it without really considering, is this in my best interest? Is this hurting me? Is this hurting the people around me? They're just doing it because that's what they've learned. Now, how might clinical anger look on the medicine wheel? Well, this is the way I've conceptualized it. You see again that the mental and emotional quadrants are quite out of balance. And here we see in the mental, we see an inability to let go of perceived injustices. So they just can't let it go. They think about it all the time. Their thoughts are ruminating. It's not fair. It's not fair. Why did this happen to me? It should never have happened. And emotionally, they feel the impact as well. They might they might be aggressive in the way that they communicate. They might be angry. They may push others away and be isolative because their anger has really interfered with those social support networks that come from the emotional, the South quadrant. And they might have a feeling of being alone because they really don't have anyone. They pushed absolutely everybody away. We can see that in the physical component in the West, there's a lot of symptoms as well. And I do want to qualify that a lot of times when we think about somebody having an anger issue, we think about them being explosive with their anger or being yelling and screaming. But somebody that has a demonstrated issue with anger as well can also internalize anger. So it can either be turned outward with some aggression and yelling and shouting and whatnot, or it can be turned inward. And so sometimes you see people that develop eating disorders, physical issues with their stomach, headaches, blood pressure issues. They may have self-harm. So instead of turning it towards other people, they turn it inward. So you can see all of these symptoms there, including exhaustion and headaches, that might take place in the physical component as well in the West. And in the East, because of all these things being so difficult, a lot of the times the client can feel very alone, and they can feel persecuted, and they can feel hopeless. So it's a really, really terrible thing to feel. Finally, the same graphic here, as with anything else when we are looking at finding balance for our clients so that they can have the ability to have good, healthy, productive lives. It goes back to helping them to recognize that need to find that love of self, family, community, nation, because that is the rebalancing part. And again, that's where we come in to help them see that part. Okay, so again, what we look at here is we always assess the variables. And as I mentioned in the beginning, sometimes we don't always think about anger as being something that could result in suicidality. But like any other issue, depending on what the variables are, we can feel driven and that we have no other options. So we always assess for safety first. As we're looking at this as well, we see that we want to do some different things. We want to start maybe in the mental or the emotional components, whatever is the biggest piece. We want to figure out what is really driving this, and that's where the assessing of the variables comes in. So it may be something that's happened, it might be a trigger, it might be some self-esteem issues, it could be just about anything that's really driving it. We want to figure out where that is coming from. So we want to do, in the north, in the mental component, we want to do some therapy that challenges the cognitions and triggers and helps them to accept more responsibility and to decrease those ruminations. We also want to do something, use a screening, use the CAS, which I'm going to talk about now in a moment, but that's where that would come from in terms of having a good understanding of what's happening and helping them to take a little bit of control with that. A lot of the stuff we would do with that would probably be CBT, or combination of other types of therapies as well. In the emotional, we want to deal with the way that the supports have been really shut out because of the behavior, because of the way that the ruminations are happening. So we might see that as clinicians, we become and doing some family therapy interventions. We may be working with them as they're adapting to managing stress in the workplace and conflict in the workplace. We want to do some therapy to help them increasing healthy expression and developing emotional language and self-awareness. That is a really big part, and most of the people that I've worked with, they really struggle with having healthy expression of what they're feeling, and so it just comes out in an angry sort of mess, and they aren't able to communicate their needs, which makes them more frustrated. It's a bit of a vicious circle there. So helping them to develop a really good emotional language is really critical. To the west, we see some of the things that we would do again after safety is established, is we would do some screening to see what the heck is going on here. Is this a depression that's driving the anger? Because we know that it can go with that. It is a really common symptom of depression. We want to see if there's some complicated grief there or some trauma. Is there something else at a physical level that is driving this? And we also want to get them to do some really healthy things to balance, which would include movement, exercise to decrease the intensity, and of course, with the medical team being involved, if there's medications that they need to take, if they have any of those issues such as trauma or complicated grief, whatnot, depression, that they're on the right combination of medication to make things feel as easy as possible for them. In the East, of course, we want to make sure that that person does not feel so alone. And so that comes down to mindfulness. Brief solution focused therapy is really useful because it can help them to remember a time when they felt more balanced, remember the time when they didn't feel as angry, to set some sort of micro goals towards working towards that regulation, and also in terms of encouraging those connections, because at a spiritual level, we really need to feel connection as well. So those are some of the things that we would work on as well. Now, I mentioned a few minutes ago in dealing with the North, we would be using the clinical anger scale. This is a tool that I've been using for a long time. I got trained in a model called Anger Solutions, I guess about maybe 13, 12 years ago. It's a program out of Ontario. Julie Christensen developed it. Fantastic little program. If anyone was looking for some additional resources. So Anger Solutions. And so I became a trainer in this model, and this was one of the tools that I picked up, but it is free and is online. But the program Anger Solutions is a really great thing that you can do at a group level, but you can also do at an individual level. And it just has sort of seamlessly sort of integrated into the way that I approach anger with my clients, in terms of being able to decrease the shame that people feel, being able to increase that feeling of you can take control, you're not pre-programmed to feel this, and there are solutions. So using this clinical anger scale is very, very helpful because it does a lot of cool things. It helps you to give your clients some really good, useful information and develop some goals, because it looks at various levels. It looks at the level of anger now, about the future, failure, anger about things, angry hostile feelings, annoying others, angry about self, etc., etc. And then some things like social interference, decision interference, work interference, those kind of things. So what it does is you do this scaling and you it comes up with, what it does is it gives you a good understanding of exactly what you're dealing with. And what I've done is there's a scaling system that goes with it as well. So it's sort of, you use it kind of the same way. It's based similar to the Beck Depression Inventory. So it's 21 sets of statements. And so they would scale them. And then there's a scoring chart as well. And so the scoring chart is 0 to 13 is minimal clinical anger, 14 to 19 mild clinical anger, 20 to 28 is moderate, and 29 to 63 is severe. So what I've done when I've run the anger solutions group is we've done them pre and post to see, how their changes might be, but you can also do it in just individual therapy as well. And so when you get the scoring, you can look at it with the client and you can say, okay, so it looks like some of these things are the bigger indicators for where the stress is. Let's develop some goals around making those things easier for you. And that's really useful for the client because they're able to sort of pinpoint exactly what they need to work on to see some positive change in their life. And so having skills like this is just a really nice add to therapy. So in terms of helping that client find balance, because it's all about balance. I want to say as well about understanding feelings, because you saw the emotional component. A lot of the times, the clients just really don't even have good emotional language for what they're feeling. And I'll find that clients will often have, 3 identified feelings. They're happy, sad, or they're mad. And there, of course, are a lot more emotion words than that. And so if they're trying to communicate how they're feeling, they're trying to be proactive, and they use those words, the people around them don't understand what they need. And so it's about understanding there's varying degrees of them. And it's about creating that language, but also that awareness of when the emotion is building so that they can take charge and they can do the things that they need to, and they don't have to result in having an outburst. And that's where it's important. So developing this really good understanding of feelings is probably one of the most important things that we can do in helping clients to feel more balanced. And when they feel more balanced, they feel healthy. So we're in our conclusion section now. As social workers, we too can integrate the principles of wholeness into our lives by recognizing that balance and health is critical for all of us. Paying attention to each of the 4 directions in our daily lives helps us to remain centered, balanced, and more resilient to careers where demands are constant. Many struggle with self-care, but if we consider integrating something from each of the 4 directions daily, we offer ourselves the best possible chance of good physical, emotional, mental, and spiritual health. Therapy is really about facilitating balance in our clients' lives. And in this presentation, we have seen how the principles of wholeness and balance can guide and inform our treatment and our priority setting with complex cases. Helping our clients embrace the concept of wellness is a holistic approach involving physical, mental, spiritual, and emotional goals can make goal setting and overall balance much more achievable. And there we are, the end. Now I'm going to pass it back to Annette for our Q&As.
Wonderful. Thank you so much, Elizabeth, for this wonderful presentation. So we've arrived at the Q&A section, and we will do our best to get through the questions. However, we do thank you for your understanding if we're not able to get to yours. Just wanted to, one of the first questions we had, Elizabeth, is around EMDR. And do you find EMDR as effective with clients that experienced a traumatic experience, PTSD, years ago versus clients who experienced a traumatic event and was seeking help immediately?
So that's a really good question. Thank you. So basically, there's a different protocol that you would do with a recent trauma. So there's the recent traumatic events protocol that is for something that's happened within the first 6 months. And so sometimes that can be pretty quick. I find the variables for me that usually is if something is a single trauma, so something that happened once, like they got hit by a car or something like that, versus something that happened over and over and over again, that seems to be more of the defining variable in terms of how effective the EMDR can be, because there may be, multiple components of it. As for the history, I haven't really found that so much. I had a client one time who had a traumatic incident happen 45 years ago who had had an awful lot of distress continually, and psychiatry had referred him to me, and I had a session with him. I was absolutely shocked because inside of 25 minutes he had processed it and he didn't think about it anymore. It had tortured him for 45 years. Now, everybody processes at different rates. It's hard to predict, but he was shocked. So it's really pretty individual, but I don't usually find that there's too much of a difference. It really impacts, what's impacted is sort of the repetition.
Mm-hmm. Okay, wonderful. Thank you. Someone is asking around DBT. So in terms of the interest of social workers in DBT, and is this also a good intervention with those who've experienced trauma?
I think the thing about DBT is it's all about emotional regulation, and certainly I think DBT is useful to everybody that's experiencing that. So yes, if you're somebody that is really drawn to DBT and that's something that your clients are having some issues with, absolutely use DBT. You can use that with any type of approach because it's really about helping that client feel sort of that increased locus of control, which is, again, impacting balance. If you don't feel like you have control, then you don't have balance. So DBT, absolutely. I certainly could have added that to the slides there. And there's probably a lot of other types of therapies that would be super helpful. When I was putting it on the slide, I was mostly just saying the things that I use, but there's a ton of them. And yes, absolutely, DBT is super helpful.
Okay, perfect. Thank you. We also had a question around grief when it's not dealing with the loss of a loved one through death, and if you could speak a little bit more about grief when the person is grieving for someone that's still living. So, for example, through a breakup or something along those lines.
That's a tough one. And the last presentation I did last year, we talked about that because there's lots of different types of grief, and I think. If we look at what's driving the system out of balance, is that longing, is that fear and grief, and that how do I live without that person? How do I, retool my life without that person being in it? And so it's about kind of looking at what's driving that fear. Is it that feeling that they don't know how to do this alone? It's about strengthening those components so that we can see more balance. But certainly it's very valid, and it's about normalizing that and say it's okay to do that, but let's see what some of the variables are that are pushing your system out of alignment and how we can strengthen them so that, even though it's understandable you're feeling that it doesn't dominate your response right now. And of course, you could do all kinds of things. You could do EMDR around that. I have. You can do narrative therapy in terms of developing alternate storylines. You can do all kinds of things, but absolutely, it's a tough one. The grief one is really tough for a lot of people, for sure.
Mm-hmm. Okay, wonderful. Thank you. We did have a couple questions around referrals, and I know, Elizabeth, you have your program, so someone's wondering how they would refer to that program, but also if someone's looking for a practitioner who uses EMDR, how would someone go about looking or trying to find someone who does that work?
Absolutely. Well, there's about, I think, 16 of us in Newfoundland, but there's a ton of us across the country that are trained in EMDR. And I think maybe a couple of my fellow trainees are here today. So hello, ladies. But EMDR Canada has a website, and they have a centralized listing of everybody who's been trained and is a member of EMDR Canada. So if you have a client that's interested in pursuing that, I would redirect them to that. And they can then you can see somebody in your area that has the training, and the contact information is there, and how you can do that. Here in Eastern Health, there's two of us who are trained, myself and Stacy Smith, who's a psychologist. Now, Stacy isn't using it in her practice because, unfortunately, she got trained in it, then the pandemic happened, so she hasn't been using it. So I've been doing virtual EMDR with my clients through the pandemic. In terms of accessing me, I work in Terrace Clinic in East End, so I can only see people within the East End geography. And if they wanted to see me, they would have to go through adult central intake and they'd have to be in my designated area, which is the unfortunate part. But again, there's a lot of private practitioners throughout the country who are trained in this, and a lot of them are doing virtual these days. So you might try EMDR Canada if you have a client that's looking for something.
Perfect. Thank you so much for that. So you did know just there in your comments around, we are in a global pandemic, and we have been for over a year now. And so have you noticed more imbalance and complexity with your clients because of this, because we're going through this pandemic?
I certainly have, and I'm sure I'm not the only person, because I think that everybody's systems and everybody's reality is so skewed by what's going on right now. We're all under pressure. I know I feel pressured, and I'm sure you do too, Annette. It's just a matter of being able to manage in a different way. And so I've found in my own caseload that I've had a lot of people recently, particularly, who've come forward and said, I'm locked in the house all the time. I'm not going to work. I'm doing these things. And all of a sudden, I sort of had this resurgence of memories, of these trauma memories that I had that I haven't thought about in 30 years. And suddenly I'm bombarded with these images. And so I think the pressure that we're living through right now, and the way that, we're not able to use our regular coping strategies, is really impacting on our just day-to-day coping. And so we have to be patient with our clients. We have to help them to be patient with themselves and recognize that, these are just really unusual times. And when we get back on track, you'll be able to get back to your coping strategies and help to normalize that everybody is going through this. But I've absolutely seen so much more complexity and a lot more levels of trauma and distress, just because people are just really reacting to what's happening around them.
Mm-hmm. Yep. Thank you. Another question. So for clients with complex PTSD who are struggling with grounding techniques and stabilization, can EMDR help rebalance to enable stabilization?
Yes. Well, EMDR is pretty effective at dealing with all that stuff. So you have to teach them some of that stuff before you get into it, because of course they have to be able to soothe themselves. So you do a lot of work around just kind of making sure that they're safe before you even jump in, because you don't just jump in and do EMDR. There's a lot of prep work that happens first. But so you would teach a little bit of grounding and self-soothing stuff as well. But you can certainly develop some goals around that even before you go into it. Some you can do at some strength building types of things, some resilience training with EMDR. So a lot of different things you can do, not just the actual processing of it. So there's a lot. Yeah, it can be very helpful for a lot of the different components of trauma care, for sure.
Mm-hmm. And that leads into another question we just received around some of that. But if you have someone who has had multiple adverse childhood events, so lots of abuse and trauma, what can we do to help clients become more grounded enough to be able to participate in EMDR? Further to what you just alluded to.
Yeah, it's a tough one, right? I think I could talk for an hour on that one. So let's see if I can hit that one quick. I think the thing about it is that we have to help that client to be able to feel like there is something they're moving toward, and that they have some goals and they have some hopes, and that they can try to find some grounding in just, it's that mindfulness stuff, being present where they are right now. Because at the end of the day, we can do a lot of different things, but they've had repetitive trauma. It's hard to trust that you're going to be okay, right? So being able to ground that person so that they can do EMDR is tricky, for sure. It really is. So it's a slow process, helping that person be safe enough to open those doors, because opening the door to trauma when they've been trying to suppress it for all these years is not something that feels very comfortable for anyone. And so you're going to do different things, like you're going to look at, how much dissociation the client has. You're going to get a better sense of that. You're going to do some different things. So, I think it's a pretty involved process. And again, it's like, certainly don't want to say that EMDR is a great thing. You do it for 2 hours and it's done. And I mean, like, I've certainly done that with the RTEP, with the Recent Traumatic Events Protocol. But I've certainly also built in a lot of grounding and prep work before we even open the door. So you got to judge your client. You got to make sure that they're in the right headspace. Otherwise, if you open up something and they're not prepared, you're going to have trouble. So it's complex. You have to make sure. Again, we always go back to the safety. But yeah, there's a lot of stuff there for sure.
Perfect. Thank you. We're coming down on our time, so we'll try to get in a couple more questions. You had mentioned early in your presentation that you are learning how to integrate Indigenous ideas into your clinical practice, and how have your clients responded to this?
That's a great question, because I do work with a lot of Hollywood clients, and so these are clients who haven't really grown up within the culture, and they haven't really they don't really understand about the four directions, and so they are really sort of hungry for that connection, and they've been really feeling validated that, okay, I understand what I can do. And just sort of explaining how the nature of balance is important to all of us, not just Indigenous people with Indigenous ancestry. I mean, balance is important for everyone, and that there are things that we can do to kind of create that balance, that if we have balance, we have control. And a lot of times in our clients, they have a lot of anxiety, and anxiety is about absence of control. So if we can teach them the things that fit within their culture, but also help them to find the control and the balance that they need, they've been really responding well to it and finding that it's been very satisfying. I've had several of them that not only have they gone, because I just try to pass on the teachings that I have in addition to, the therapy part. A lot of them have really gone on to, I have a couple of them now that are doing the language course, and one of them just did the culture camp. So it's like it's really sort of lighting a fire in them in terms of their own cultural connections. So that part's been really lovely to see.
Excellent. And I guess as a final question, would you use the medicine wheel with non-Indigenous clients, or is this something that you would primarily use with your Indigenous clients?
Sure. Well, I think that was the one thing that I was a little bit nervous about presenting today, because I certainly don't want to be responsible for any cultural appropriation or anything like that. I mean, I'm an Indigenous person, and I use it because I'm an Indigenous person. But I think that the principles exist separate from the medicine wheel. So I'm not suggesting that everybody get out there and draw a medicine wheel for their clients if you're not Indigenous or your client isn't Indigenous. I'm saying let's take the principles from this framework and use them to help our clients find balance, right? So we would say, okay, well, what's going on? Do we feel like, okay, there's a lot more pressure going on in, the emotional parts of your life. So let's deal with that. So you don't have to draw a medicine wheel in order to help your client achieve balance. And I certainly wouldn't encourage you to do it if you don't have that connection, because I guess, this is something we don't want to sort of wander into if it's not where you are. But I love that the principles are so universal, and they're not just applicable. These ideas didn't just come from the Indigenous community. We're looking at, the Chinese culture has had these for thousands of years. It's just the way that we as an Indigenous community for all these years have operationalized that as a way that's meaningful for us. So no, I wouldn't do the medicine wheel unless the client was Indigenous or unless I myself was. But again, we can still use all of these ideas, and they're very, very relevant to whatever client we have.
Mm-hmm. Wonderful. That was a great response. Thanks, Elizabeth. I'm sure we could go on for longer, but just respecting people's time and also Elizabeth's time, we will wrap up. So I do want to thank you, Elizabeth, for this informative and stellar presentation. So much information was covered, and I think regardless of people's areas of practice, they will come away with some new learning and new information that they can integrate into their work as well. I just want to note, Elizabeth, that your passion for this work and for promoting continuing education is inspiring. And your pride as a social worker is also evident, which I do want to point out that Elizabeth Elizabeth was the recipient of the 2019 NLCSW Pride in the Profession Award. So I just want to put that in there too. So thank you, Elizabeth, for your willingness to continue to share your knowledge, expertise, and experience with your fellow social work colleagues. This was number 3. We look forward to at some point number 4. It's just wonderful social work promotion. So I do thank you for joining us again today. Just to let people know, the PDF of the PowerPoint presentation is available in a handout section of the webinar platform. And this webinar will be available on demand in 24 hours using the same link that you used for the live presentation today. For NLCSW members, a recording of the session will also be available on our YouTube channel in the coming days. And also Elizabeth's previous webinars, the 2 other webinars that Elizabeth presented nationally can be accessed on the NLCSW website and also on the CASW website. So if you're interested in reviewing those again, or if you weren't able to attend previously, those are now there for your viewing as well. So before signing off, we do ask that you will complete an evaluation form that will appear on your screen, as your feedback is always greatly appreciated. And thanks again, everyone, for joining us today, and stay safe.